Welcome to Endocrine Uncovered, where Dr. G, board-certified endocrinologist, Tanya and Stacy, nurse practitioners with a knack for making hormones make sense, squash hormone myths, and answer the questions your Google search history is too embarrassed to admit. Welcome to Endocrine Uncovered. Hi, y'all. Welcome back. Really welcome back. We've been gone for a while, but we're back again after taking care of personal life and ready to record. We also have a new format, so if you see us figuring things out, it's because we're on Zoom now. I'm Tanya. I'm one of the nurse practitioners on this podcast.
I'm Dr. G.
And I'm Stacy.
And today we have a really juicy topic that we're going to talk about. It's something that we get questions about every single day, and that's testosterone replacement therapy during menopause.
It's a good one.
Sorry, I was waiting, Stacy, to make sure your audio was showing up because you weren't showing up, so I'm just looking at you. Okay, I can see you now.
Yay. So this is a question that we get all the time. Do you get this from patients, Dr. G?
I do. I would say multiple times a week for sure. And sometimes it's driven by social media, but a lot of times it's maybe a friend that told them that they're doing some and they feel better, and or they're just kind of wondering if there's a better option for them for what they're doing. And I think that, hormone therapies have recently evolved, right? Again, we're starting to really embrace that again, and I think there's a lot of questions that go around that.
Absolutely.
Yeah, it's true.
I tell people we have a good 25 years worth of research, but that's it. But in the last 10 to 15, we've had some really great advances in our research in women's health specific to hormone replacement therapy.
Yeah, and I'm going to put a plug into our last podcast that we did. So we've already done a podcast on hormone replacement therapy and what the guidelines suggest. So if you haven't already listened, go back and listen to that. But that's where we talked about estrogen and progesterone mainly. So today we're going to talk about the role of testosterone in this regimen as well.
That sounds great. Let's start with a case.
Yay.
Okay, so I had a 45-year-old woman come into clinic. I was seeing her for something else, thyroid, I believe, but she came in and she had a total hysterectomy about a month prior. Started having a lot of complaints of hot flashes, sleeplessness, dry skin, joint pain, muscle aches, hair loss, just itchy, itchy and bitchy, just like that first podcast. It just did not feel well and felt like this was not her life anymore. The sad thing is she wasn't offered any HRT.
Okay. So it sounds like she's experiencing symptoms of estrogen deficiency.
Yeah.
Now,
Why did she... Oh, sorry, Stacey.
No, go ahead.
My mind is like going all over the place. Why did she have to get a hysterectomy?
So, oh my gosh, you guys, I just have to tell you this. And I know that this is like part of our Zoom, but I am sitting in my office and there are these elk that are totally fighting outside of my window. And it was so distracting, I had to look. Anyway.
I thought she was going to say she was having a hot flash.
No, I wasn't. But that was so cool. All right. So,
Oh my gosh.
Do we know why she had the hysterectomy?
You know what? She had an elective hysterectomy.
Okay.
She wanted to have everything removed. There was BRCA in the family. She was just very worried. And so she just felt like she had a mastectomy and a total hysterectomy.
I feel like that's a little, the answer to what you do about that might depend a little bit, though, on her history here, right?
Right, yeah. She did not have a history of breast cancer.
Okay, so just family history.
Okay.
Yeah.
Okay. Well, based on our former podcast, I would say we need to have a discussion with her about, do we need to start some estrogen for you for lots of reasons, not to mention the fact that she's having side effects, the hot flashes, the sleeplessness, the joint pain, the itchy kind of symptoms, but also she's 45. It's a little early to be going through a surgical menopause, a menopause. They say natural menopause is 45 to 55, so on that early end there. And so what about things like her bones and her cardiovascular health that we need to think about?
Yeah, definitely. I think it's a good time to have an informed discussion. I understand she's trying to reduce risk, so we have to talk about kind of what additional risk we would be introducing if we did hormone replacement therapy, but it might be less than what she initially thought.
Yeah.
Yeah.
So she did get started on estrogen.
Okay.
Did not do progesterone initially.
Because she doesn't
because
need it
she doesn't have a uterus.
necessarily. I
So.
mean, medically doesn't need it because she doesn't have a uterus anymore.
Right, right.
Right?
So she starts to feel totally better.
Mm,
Like
good.
I'm seeing her. I saw her 6 months later again for a thyroid, and she's like, "Oh my god, I feel so much better. This has been a life changer." But
Mm-hmm.
then, and she's like, "This is who I was, and I'm so grateful and thank you." And so, but then about a year out, she comes in and she's like, she's like, from a thyroid perspective, I think I feel fine, but I don't feel great in my personal life. She said she has zero interest in any sexual activity, and it's created some relationship problems for her, and she feels like her life has drastically changed, in that she really hasn't had sex in a year and does not want to,
Mm-hmm. Mm-hmm.
and
Now, did you
feels
have a
like it's a.
conversation? Did she have any issues with vaginal dryness? Is that part of it, or was it really more the libido, the
Good
drive, the
question.
interest?
Yeah, good question. So I did add vaginal estrogen when I added the systemic estrogen. So systemic estrogen I would put her on was the estradiol patch, and then I
Mm-hmm.
also gave her estrogen
Okay.
vaginally.
Okay. So, but then she's felt like if she could, build up the interest to have sex, it wasn't an issue with pain with intercourse or
Right,
dryness, something like that. Like
right,
that wasn't
right,
the issue.
right.
Okay. So then I would think she would meet criteria to have a discussion about testosterone.
Yeah. And before we do that, we want to kind of go through some other stuff too,
Mm-hmm.
right? Because, and Tanya, maybe you could talk a little bit about that, but because libido is so multifactorial.
That's so
So,
true. Yeah, I feel like I always kind of open up that discussion. Our sexual desires are closely tied to what's going on in life, right? So let's talk about stress levels. Are you really stressed? Are you grieving something? How is body image? How's your relationship? And I think it's important to talk about these things with your medical provider because they make a big impact on your life and just
yeah,
on your health. So after we've addressed all of those things and it seems like, that's not
yeah.
what's going on, then I think that it's good to discuss options.
Yeah, I always tend to make light of it
Mm-hmm.
with patients so they can feel more comfortable.
Yeah,
But
yeah.
I'm like, I know that a lot of women will be like, I have zero interest unless like I feel extremely beautiful and the lighting is just perfect in the room and all the laundry's done and the dishes are done and the counters have been wiped off. Like there's so
Yeah.
many things that women need to have check marks for, that sometimes people just need to kind of understand that they're also not weird, to have a lack of interest, but is it really impairing your quality of life and the quality of life of those that are very important to you?
Yeah.
Yeah.
We're complex human beings with complex needs sexually,
We are.
emotionally,
Yeah.
psychologically, all of them.
Yeah. So let's just kind of circle back and say
Mm-hmm.
the primary treatment is for whether it be surgical menopause or natural menopause, the first treatment is always estrogen.
Estrogen.
Mm-hmm.
Yeah.
Hmm.
Yeah.
Hmm. And then you
So,
didn't give her any progesterone. And so one of the questions I would ask her is,
yeah.
are you sleeping?
Right.
Because if
Mm-hmm.
estrogen wasn't enough and she's exhausted because
Yeah.
she's waking
Mm-hmm.
up constantly in the middle of the night, which is affecting her emotional ability. And she's like, I just want to go to bed and I'm too tired to even think about having sex right now. That sleep part probably should be addressed, which in some women, progesterone can make a difference even if they don't have a uterus. Sometimes we will use progesterone for that.
Mm-hmm.
Hmm. Yeah.
And
But for the purpose, I think, of this podcast, we'll just talk about, okay, maybe she's sleeping good and really she meets the criteria for a condition that we call HSDD, hypoactive sexual desire disorder, low
yeah.
sex drive.
Yeah. And Tanya, are you still engaged? I want to
I
make sure
am.
your camera's still working. Okay, good.
No, I am. I am.
Okay.
Yeah. I am. I actually was thinking about, what her options could be. And I think obviously testosterone replacement therapy is something that we can talk about. But I also tend to think about some SSRIs. And now most recently, Addie got approved
Yeah,
for hyposexual desire disorder. That's a long one.
it is. It is.
So
HSDD, we'll call it.
HSDD, yeah. So talking to patients about that too, seeing if testosterone really is not something that they're gonna get a lot of benefit from, we still have options, and
Yeah.
so we can touch on those as well if we need to.
Is that how
And
you say
then,
it? I always say, in my brain, I say Addie I.
I have,
Oh,
Addie?
because it's spelled like Addie I.
yeah,
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 Addyi. I say
yeah,
Addie.
I don't
yeah,
know.
yeah.
I'm like, Addie to me sounds like just like a cool
Yeah,
girl, you know?
yeah,
She's just
yeah.
like breezing through life.
Um,
Happy sexually.
Uh-huh.
well, there's that. There's a second one too, and I'm blanking on what the second one is. It is. I'll think of it in a second. I'll come back to it. But you got to be careful because this is not Viagra for women. So you know the internet's messing this up, and these two drugs are being used for like saying this is Viagra for women. These drugs are for sexual desire. They're not going to cause engorgement of anything, so they're not Viagra. It's very
Yeah.
important to understand that this is for sexual desire, libido.
Yeah, they work on the neurotransmitters, some of the same neurotransmitters that different SSRIs work on, like serotonin,
Yeah,
norepinephrine, and so the thought process, a lot of it occurs in the brain, which
yeah,
I think is really cool because libido really has a lot to do with
yeah,
our brain chemistry too.
yeah,
Correct.
yeah.
Yeah.
And so let's kind of talk about how, so, we said having a low libido is a functional thing that happens for a lot of women. And when is it becoming HSDD? And when does it meet that criteria for where it is vastly impairing your quality of life? And that is a really hard thing. And I think in the studies looking at HSDD, it's really hard to capture that. But if we just look at incidence of HSDD. So for younger women, so women that are 18 to 44, the incidence is about 7%. And then for 45 to 60 is a bit higher. It's actually 44 to, I think, 64. That's about 12%. So that's the highest range. And then it drops back down to 7% in women that are over 65. And, so the dysfunction goes down, but also I think women that are over 65, the distress associated with it goes down.
Oh, interesting.
Yeah. And then I think this is also another good time to talk about normal testosterone fluctuations throughout the lifespan of a woman.
Sure.
We actually have our testosterone levels slowly decline actually after the age of 18, but they're still normal. They just slowly decline. And so when menopause happens, you actually don't get a abrupt drop in testosterone like you do with surgical post-surgical menopause. Like menopause, you get the estrogen right away. Natural menopause for women, you don't get that. You get like a very slow drop, and then when you go through menopause, it doesn't just fall out.
Yeah. It just kind of gradually keeps coming
Kind of
down.
gradually keeps going. And in fact, a 60-year-old woman, it actually peaks back up. Which is why your grandmother might have been like, oh, these dark hairs. They would really complain about symptoms of, they're like, why am I getting this now? Or even acne. I don't know if you've seen women that have come in their 60s, they're like, why am I getting acne and hair right now? And that's actually a normal rise in testosterone that occurs at that age.
I had a grandma that would have me pluck her chin hairs.
Oh, yeah. Oh, we all did. We all did.
It's true.
Yeah. Yeah. Yeah.
Okay. So let's talk about the options for the type of testosterone that we can use to treat here. So men have several options. They have injectable with a needle, they have patches, they have creams, they have gels. There's one that you can even put inside your mouth and it absorbs in through your gums. And then men have pellets, little rice-sized pieces that can be inserted into their backside. Women, what do we have?
Nothing yet.
Nothing yet.
We have
Nothing
no
yet.
approved forms of testosterone for women, yet we have an indication that we can use it in women.
But no viable options.
And this indication is not new.
No,
It's not.
No, this is not new at
No.
all. So I kind of wanted to back up and tell you guys about this testosterone patch that was devised for women. And this was in 2004. And it was, I forget who made it, maybe Procter & Gamble or something like that. But they had this, it was tested and it was actually efficacious. It did help quite a bit with libido. Now, when I say quite a bit, I mean the desire effect or the distress around the desire effect was efficacious. The amount of sexual events that occurred was only one per month. So it's not like we're rabbits, right? It's not greatly increased the sexual encounters, but the distress and that one episode made individuals feel more alive. It made them feel good. So it was a positive study, and it was set for approval. And then the FDA had met in December of 2004, and they actually voted it down.
Why?
And
Why?
the reason they voted, and it might have been even unanimously, I can't recall, but they voted it down. And there's a couple things to remember here. Number one is the declaration on the Today Show about estrogen hormones are bad was 2002.
Yeah.
So this is 2 years after. And what we didn't know is really long-term effects. We didn't know this was not a long-term study. This was looking at sexual desire and distress. And that was helpful. But what we didn't know is, could this be associated with negative effects cardiovascular wise, or with breast cancer, where we're going to see negative effects that we're seeing in that WHI study with this drug. And at the time, there's a very well-known endocrinologist who I have a lot of respect for, Dr. Nissen. I'm sure you guys have heard of him, but he actually was like, why would I approve this drug for one more sexual encounter per month and increase the risk of cardiovascular disease? Which we don't know, because we just didn't have the studies. So it was voted down.
Yeah. And coming right off the WHI study where everybody was afraid that all hormones in women caused cardiovascular disease, it makes sense at the time. Now, did they study it in conjunction with estrogen and or without, or did they, do you know much?
I don't know. I don't remember.
I'd
have to go back and pull it.
Yeah.
I think my problem with that is like, okay, now what? Like, why aren't the studies being funded? Why are we not doing longitudinal studies where we're looking at these long-term, side effects or just impacts of these medications? I think that's what we're really missing in women's health, is the initiative to look further.
Yep.
Is that a facetious question?
What?
It's perfect.
Is that a facetious question?
Facetious.
We're not going
It
to
is
get anywhere,
facetious.
by the way, on this topic.
I mean,
P.S.
yeah,
Near
look
future.
at our world.
We need
know.
women's research. Thank you.
Anyways, we're not going to get there right now. But that actually, Tanya, is a very important point, because I think what you're alluding to is that women are now feeling desperate because there's no good answers and there's no funding to improve women's health. And so women then are looking for answers. And unfortunately, a lot of these answers are coming from people who do not understand the physiology of women and don't understand the risks and benefits. And what they also don't know is that we don't even have the right lab assay to measure testosterone in a woman. Yeah. So we're kind of back to this, blind leading the blind kind of thing.
I have women that come in a lot that say, will you check my testosterone? Because, I heard that I might be low, and or my other provider checked my testosterone. They said I was really low and I need to replace it.
It's like none.
Yeah, it's none. They said I have none, and well, that could be normal for your age. That could be the assay that we're using. It's not the best science behind checking testosterone.
Yeah, and the time of the day, it was checked.
Yeah.
Yeah.
Yeah, time in their cycle, if they are still periodically having periods, or are they officially postmenopausal now?
Yeah.
I'm sorry, as we started to talk about testosterone more and more, I started to glow more and more.
I'm looking at that.
The
I'm
sun
like,
is
"Did I
coming
text
in."
and tell you that you're like,
you look fantastic.
And you know what I love about this though, this glare, is that it's multicolored.
It's true. It's a rainbow.
It is a rainbow.
And that's much like testosterone replacement therapy in women. It's a rainbow. It's you can have a little bit, you can have a lot, depending on what your body wants and where you feel good. I feel like as a PCOS girly, I'm like, the testosterone is 0. That sounds fantastic. Sign up.
Yeah. Some people would like to get rid of the facial hair.
Can I please? I wouldn't have to spend as much money on laser.
Yeah, I know. Okay, so let's talk about actual treatment.
Yeah.
And how as providers, having no approved testosterone for women, how do we find testosterone for women for this disorder?
Yeah.
So what are our options?
So we have our compounding pharmacies, right? Where a good one is the one that we typically use, the one from Mayo Clinic, where you can get that. I like them because they actually follow FDA guidelines.
Yeah.
And it's hard with compounding pharmacies because you don't always know what you're getting, but that's an option. It's not always the most accessible option.
Yeah.
And then just a note on compounding pharmacies, they're supposed to have this kind of somewhat of an FDA oversight. There are certain rules that they're supposed to follow. They are supposed to do tests on their products to say it is in fact pure and it's got this percentage of this ingredient, and they've spent extra money to do those lab tests. But not every compounding pharmacy does that because it costs extra money to do that, which then is passed on to the consumer, and then maybe they can't be competitive and sell their products as much. So it's tricky with compounding pharmacies. Okay, and then we have our men's testosterone, the topical kinds, whether it's the foam or the gel, or we can use those, but it's pretty willy-nilly,
isn't it? Yeah, because first of all, even a half a tube would be too much. And you're like,
so most men will do 1 or 2 tubes per day that they place on their skin, usually kind of shoulders, upper chest, that they would place it.
Yeah. And then so we're kind of like, well, we kind of want to use like an eighth of a packet, which is really hard. You're like, you put a little teeny tiny dabble on there and then you rub that on. The other thing though for women you should also be aware of is that, anytime you're doing the gel on there, you would need to put it somewhere where you're not going to be like hugging someone or touching someone that you don't want to have transference of that. Of like, you're like taking care of your grandbaby and you have testosterone gel you put on your arm and you go and you're hugging your baby, that's going to transfer, and then baby will start to have some testosterone side effects.
Because for whatever reason, and it's not even clear if there's a scientific reason behind this, we're often tell women to put it like on their arm, kind of somewhere on their forearm or their, below their wrist, kind of, which is not an often covered place.
Yeah.
Arbitrary too.
Yeah.
Although I've people put it on their thighs.
Yeah. But sometimes they'll say hair started to grow there.
Oh, yeah.
Where they place the testosterone.
Yeah. So the bottom line, though, is that we just do not have any clear guidance. We don't have any ongoing trials that we're going to be able to pull from in 6 months or a year from now. And so right now we're kind of flying by the seat of our pants.
But we do have some guidance on, we can start with a dose, see how it goes, see if it makes a difference symptomatically, check their labs.
Yes.
And we're aiming, there's a couple of thoughts about this. There's the guidelines that say aim for sort of normal range testosterone, so kind of where a younger person's testosterone would be, which is either anywhere mid to upper range of normal. And then we have some other guidelines or some other experts, in this field that say, so a normal testosterone assay normal would go up to maybe 45-ish. And then some people say, well, maybe we aim up to 60 to 80 in these women. So just a little bit above that normal, but then also watch for signs of excess testosterone. And if those signs bother them, like facial hair growth, thinning of their hair, kind of like that balding in the top, deepening of the voice, too much sort of emotional ability or anger, acne. Any of those symptoms, maybe it's too much and we need to back off.
And I will say, I think that for any of these hormones, estrogen and testosterone, so much of it has to do with just genetics too, of how you're going to respond to that specific hormone. Some people will feel the hyperandrogenic symptoms of testosterone way earlier than someone else, just depending on what their family looks like, and what their background is. So that's important too, to just kind of keep an open mind that doses will differ for different people.
If you're not really wanting to have the side effects of the excessive testosterone, if you're not wanting to have facial hair, you're not wanting those side effects, and you're seeing a provider that checks your testosterone and it's coming in already at 90 and they're wanting to up your testosterone dose because maybe you said you're tired. This is not the role for this. This is not to treat fatigue. This is not to just give you a drug to make you feel better. It's to get your sexual desire to goal and minimize side effects.
Yeah. So, oh shoot, I forgot what I was going to ask. There was one other part of, oh, I know. How long do we wait before we decide if it's working?
If the estrogen therapy alone is working,
No,
or
if once we've added testosterone, if it helps with libido.
mm-hmm.
That's a good question.
That's a good question.
Do you know it?
I do.
No. I don't have a clear answer.
Yeah.
So the guidelines say 6 months.
Yeah.
Oh, 6
And it's
months.
after
Okay.
6 months.
Kind of like the weight loss medicines.
Yeah.
Like, you know, if you're not getting anywhere at that 6 month mark, you should stop it.
Yeah. Yeah. They said if it made any difference, it's going to within 6 months. If it doesn't, it's not, it doesn't matter for you.
Yeah.
And maybe 6 months and we've adjusted the dose to be at the right place based on labs too.
Right. And first you've done that estrogen to the right level. Oh, there you go. You get the estrogen to the right level, and then you're adding the testosterone for libido, not to treat the menopausal vasomotor symptoms. That's not the role of testosterone.
Yeah. Okay. All right. I think we have an applicable hormone hotline.
Oh. Hormone Hotline. Tanya speaking. How can I help you? Hi, Hormone Hotline. This is Jessie from Denver. My doctor told me that I can put all 3 of my hormones together in one dose. I'm wondering whether this is generally recommended, or if there are reasons to keep hormones separate for HRT. That's a good one.
That's good. Particularly based on what we just said, right? Because we're like, there's nothing FDA approved for women, let alone a tri-hormone, 3 all different hormones in one.
Yeah, and also, like we said, all of this is build your own adventure for every single different body type. So putting something in that's a general dose for everyone,
Yeah.
quite lots of questions about that.
There are lots of questions, and there is technically something available that has estrogen, progesterone, and testosterone included. It's not FDA approved, but it is available. However, I think we're going to pause on that one and wait until next episode where we talk about it.
Yeah.
Oh yeah, so come back next time to hear the answer.
Bye,
Take care,
everybody.
Bye.
Thanks for tuning in to Endocrine Uncovered. Follow us on Instagram at endo.uncovered for tips, updates, and behind-the-scenes content. Have a question to submit? Email us at askhormonehotline@gmail.com. Don't forget to like, subscribe, and leave us a comment. Listen to us wherever you get your podcasts. Until next time, stay curious and take care of your hormones. The information shared on this podcast is for educational purposes only. Always talk to your doctor or healthcare provider about your individual health needs.